We're live. Okay, Facebook is rolling. Gonna get Instagram rolling here. And we're live on Instagram. Awesome. Happy Friday, everyone. Good morning. My name is Julie. Welcome to the MMOA podcast brought to you by the Institute of Clinical Excellence. I am so incredibly excited to bring this interview to you guys live this morning. It's so cool you don't have to stare at a Zoom screen because Maddie is actually here with me in person. So I'm going to introduce Maddie. She's got, the letters after her name, the things that she's involved in is extensive. So I'm just going to kind of read off my notes here so that I don't forget anything. So Maddie is an OT. She is a certified brain injury specialist. She has her master's in science and health promotion. She is certified. She has her CrossFit level 1 certification. So clearly she's incredibly fitness forward, which we love. She is adjunct faculty for a OTA program. She has edited a part of a polytrauma section in an OT and OTA textbook. She is a board member for the NCOTA, so the North Carolina Occupational Therapy Association. She's been doing OT, especially in critical care, for the past 7 years. In addition to all of that, she's also a wife. She is a mother to little baby girl Sophie, who just turned 1 year old. And last but not least, she is one of my nearest and dearest friends. We met when we were pretty new grads right off the bat, working at the hospital together. So I'm super excited because these conversations are things that me and Maddie just talk about all the time. So it's just gonna feel like another day as Maddie's driving to work and we're chatting, talking about all this stuff. So we're so excited because there are so many of you out there and listeners who are PTs or OTs and are thinking like, is acute care right for me? Or you're in it and you're thinking, I want to get the heck out because I want to go beyond the medical model. So the really cool thing about this conversation is that Maddie is kind of in the thick of this, right? Yeah. Like she's been in the medical system for forever and she's now just starting to kind of step out of it and discover and create what her next step is going to be. So we're going to kind of hear the thick of the journey, which is going to be awesome. So thank you for being here and spending this time.
I am so excited to be here. When you asked me, I thought, okay, how do we do this in person? Because it will feel way more natural for us to be face to face to do it. And I'm just so excited to be here and hearing you talk about all the things. I was like, wow.
You do a lot. I'm pretty freaking awesome is what you should be
like, what's wrong with me? Why am I doing all this? But I mean, I truly, I love OT. And honestly, what sparked this change of direction a little bit is actually us working together on that presentation about how to provide holistic fitness forward care, because I went back to look at the occupational therapy practice framework and thought, we do a lot as occupational therapists, but for the last 7 years I've just thought this is how it is,
right?
So actually working with you kind of sparked that change.
I love it. I love slowly pushing Maddie, every time I'm talking to her and she's really frustrated from something with work, I'm like, maybe this, or maybe you could do so much more, right? And I'm sure so many of you are probably tell yourselves the same thing who are kind of grinding it out in the hospital. So that's awesome. I love it. I'm gonna keep doing it. Keep pushing you along. Okay, so let's start with talking about being in acute care, being in the medical system. So there are pros, there are cons.
For sure.
I would love to hear you talk about what are the positives? We do talk about the negatives a lot.
We do.
Let's hear what are the most critical lessons you've learned from working in that setting. What has it given you that maybe is going to be setting you up really well to move forward? Yeah. So let's talk about the positives first.
So I would say the critical lesson that I learned is no matter what situation I'm dropped in, I know I'm going to be okay. I can handle any situation. I can handle anything that's thrown at me, period. I don't really get nervous. I mean, even for this, when we were kind of preparing this morning to start, I was just like, yeah, let's just do it. You know, like I didn't feel uncomfortable, because critical care or acute care is just, you're on your toes all the time. You see all walks of life. You have to deal with multiple kinds of personalities, both from patients and other staff members, that, I don't know, you just get really good at anticipating the unexpected and just rolling with it. I love that. I love that acute care has a work family, at least for me at my hospital. I feel like there's always somebody there, whether it's a therapist or a PA or a nurse practitioner or a nurse or a CNA. There's always somebody that I can talk to about something if I have questions or concerns. It has a really great work family. I don't have to worry about, oh man, if I don't see these patients, I'm not going to get paid, or I'm having to scrounge to try to find somebody. Yeah. I like that there is always something to do, because I'm somebody that's like, all right, I got to keep working. I don't sit very well. Yeah. So I like that I don't, A, have to find somebody, B, get worried if I'm going to get paid or not. Honestly, even after 7 years, weekly at least, I'm always still looking up something. I'm still like, wait, what is that? Or I remember that from school, but it's been a really long time since I've had to do this. I need to look this up again. I like that I'm still challenged as a forever learner, essentially, in acute care, because truly there is something all the time. Yeah. But yeah, I mean, like you said, there's so many negatives that I could say about it, but I do feel like it has given me the confidence to know I really can do anything. I may have to be okay. Yes. Regardless. I may have to research it and look it up, but I would be okay.
And this has reminded me about the situation you were just in, which we don't need to get in detail about it, but Maddie literally had to do CPR on a neighbor. And again, just the idea that she was in a situation where emergently you had to act, and especially doing something like CPR on someone, and you're not in a hospital, you are literally at home, and you're having to go over to a neighbor's house and do that act. That's exactly, like, I told her, I'm like, you are the person that I would want to be in like an emergent situation. And I think that's just who you are as like a human, but I think critical care and being in that environment where shit is literally hitting the fan constantly can prepare you to just act and be able to keep your cool in very, very difficult, challenging situations.
For sure.
Which is awesome. And it's interesting, like how you mentioned, there's things about acute care that people don't realize that is really helpful. Like, you get paid when you're there. Like, if your patient is not appropriate, or you walk in the door and they're like throwing things at you, and you're like, not today. Not today. Yeah. You walk out the door and you go down the hallway to another patient. Like, when you are in home health, now I'm seeing so many differences being in that setting. That doesn't exist. You can't just go down the hallway and see another patient, right? You're out on the road. You're not going to get paid for that person if they refuse you, things like that. So there are so many benefits to it. I will say right now, and this is probably maybe an unpopular opinion, but, and I've said this to you, I feel now, having done both settings, I can give better care actually in acute care than home health, just because of like the time factor. Like, I can spend as much time as I want with someone in acute care. I'm not worried about, I'm getting paid for that time. Home health, it's just a different story. So we wanted to talk about some of the positives first, because there are a lot of things on the opposite side that are very prevalent and much more front of mind, I feel like, in a lot of the conversations that we've had. Yeah. So let's go there. Okay. So we're doing it. When you think about, and it can be like hospital in general, or OT role in acute care in general, like the things that make your blood boil, that frustrate you, that burn you out, that helped to kind of lead to a point of like, I just, like, this isn't for me anymore. I don't feel like this is serving me in the way that it used to anymore. Tell us about that part.
Oh man. Okay. So no,
she's still gonna find a way to spin it in this beautifully positive way, because this is just a skill that she has. But
so on the way down here, my husband and I, he's also an occupational therapist, we're talking about it, and I think honestly from the get-go, whether PT or OT, I honestly think in school you're in it thinking, I'm going to change the world. You know, they just give you this mentality of you're going to get all these skills, you're going to change lives, people are going to be so appreciative of you, you're going to do amazing. So you leave school thinking, I'm going to change lives, like I'm a superhero.
Yeah.
And then you get to your traditional setting, whether it's hospital, skilled nursing, outpatient, inpatient, home health, I'll kind of put those all lumped together as traditional setting. You realize how quickly people put you in this box. I think for both professions, and if I can be bold to say it, I think even worse for OT.
100%.
People think, OT, first off, what is that? I don't do it, I don't work. I'm like, that's not just what it is, but you know, also like people put you in this box of self-care, right? Like
Yeah.
They just want you to work on bathing, dressing, toileting, grooming. We'll use those. Yes, that is kind of one of the founding things of occupational therapy is self-care. But in the hospital especially, it's, let's say I walk into a room and a patient has been incontinent, whether it's urinary or stool, you know, let's say at this point they need total assistance, meaning you have to help them get dressed, you have to help them get out of bed, all this. Oh great, OT is here, you can help me clean this patient up. I cannot tell you how frustrating that is, because I'm not above helping at all.
Right.
I absolutely will get in there.
Right.
I 100% want to help, because I understand like nurses and CNAs, they have so much stuff that they have to do that if the least I can do is help you, absolutely.
Yeah.
But to just think, oh, OT is here, you can help me do this, they totally take away the skilled component of that, and it just makes you feel, I don't know, it's kind of demeaning, you know? It's like, okay, I guess that's all I am, but cool. And even in the setting that I've been in, again, I can't tell you how many times to providers that I've provided education. Like, I hear you, and this is also what I can do. Like, we could be getting in way before physical therapy, especially for the critically ill patients that are bedbound.
Right.
We can be working on cognition, we can be working on socialization, we can be working on sensory stimulation, we can be working on range of motion as part of that. But I don't know, people either A, in one ear out the other, don't know, super frustrating, or it's, oh great, you're here to come walk the patient. Like, first off, no. Second off, that's not just what y'all do either, you know? And so it's just, and you just get to that point where you're like, I don't want to have the same conversation
over and over again.
And so then I think you just finally accept that as your role, whether it's PT or OT. I feel like you just think, okay, I'm tired of fighting that fight, and I'm just gonna show up to work, and I'm just gonna do what you think I'm supposed to do, and I'm tired of dealing with that. And I think part of that leads to the burnout too, of just like, okay, well, this is what I'm gonna do, and I hate it. To that point, you know, I don't hate working with my patients. I hate being put in that box of what people think it is. Yeah.
And it's so tough, because we know that exists, and then you start to think, I went through this too in the hospital, like, well, can I change it? Can I get a certain amount of people on my side? Can I educate providers so that I can have somewhat of an ecosystem that is going to do things in the right way, right? Or they're going to not just consider me in a box. Like, if I do this for long enough, can I make this big change? Can my coworkers start to get on board? Will physicians start to treat us differently? And I'll say how what my conclusion was after. I want to hear yours first, but I'll just ask the question, like, at this point right now, do you feel like this battle is something that people who are in your same situation like we can change how this is perceived in the medical system. It's hard to see your face. Can we change it? Do we do that? Or is it, you get the hell out because it's not going to change, unfortunately, because the medical system is the medical system, and your philosophy is A, medical system's philosophy is B, and that they aren't playing with each other.
So my hopeful answer is absolutely. Like we can keep pushing, we can keep doing it, we can change it. My realistic, after trying to do it for that long, no.
Yeah.
I don't think so, because let's just say, so I've been pretty much the same work assignment for those 5 years. So I've been talking to those same people for the last 5 years. Like, I know that doesn't seem very long, but
a long time.
It is when you're doing that day after day after day after day.
Yeah.
So my realistic side, no, I don't think people want to change.
Right.
I think it's easier to say, well, this is how it's always been, so we're just going to keep going on this path. It's harder to make change.
Yeah.
And I think that's even true for patients too. You know, I think that's also a con, is one tough lesson that I've learned is you cannot change someone who has no desire to do it whatsoever. You just can't. You know, they pulling in like health promotion mindset, there's different frames of reference for motivation. If someone's not even in this preconception phase, meaning, I thought maybe, let's just use weight and nutrition, because that's, I think, the easiest example people can wrap their minds around. The preconception is, I should probably lose weight. That's all it is. So if they're not even there, you're coming in telling them, oh, like your joints would feel better, you could move better, you could do X, Y, and Z better. It's like, I don't even know what you're talking about, because I'm not even in the preconception phase.
Right.
So I feel like the providers too are also like that. It's like they don't even have that desire to change. They don't have that desire to think of this in a different way, because this is all that they've known. And again, tying it back to after rereading the OTPF for the millionth time, I thought, oh my gosh, we are just so much more than this. And I don't think taking that piece and putting it into the medical model is what's going to work. It has to be something currently separate. Maybe one day I would love that. But in the current state, that's not how it is.
Yeah. And I mean, I know we experienced this both together at the hospital that we were working at, where we worked with some amazing individuals who were trying to push that, and our ICU mobility program was really, really good. And you see these pockets of hope, I guess, where people, like, you're starting to really do things that are fitness forward or more holistic or using your full scope. And it just felt like you make some progress, and then those people who are in that realm of wanting to change just dissolve, or they turn over. And it's like, even like our colleagues who are still there, it's like you hear the same story, progress, and then it's back to the same BS. Progress, and it's back to the same BS. And I think it just goes to say that, like, that is just the medical system in itself, and trying to bring that in and make a change, like, hopefully, like, may happen at some point, but for the most part, probably not. I don't think it's incredibly realistic.
Because it's not just us, right?
Right.
It's everybody. I mean, I was even just thinking, I'm like, man, we all have to play this game, right? So let's say you're trying to so the ultimate goal for the hospital, get someone discharged. Right. Whatever that is, whether that's to a facility, home, whatever, everyone's playing the game. It's, well, you have to say X, Y, and Z in order for this thing to happen. I know we can't do this, but I'm like, okay, we all see it. We all recognize, man, this really isn't the way, y'all. You know,
like, case management is like, I know that this isn't really what is probably going to be the best thing for the patient, but, like, we have to do it this way, or, like, I need you to put in your note this, or, like, you can't put in your note this because of insurance, or because the doctor wants them out right away.
Yes. It's like we all see it, you know, but it makes me think of that commercial. I don't know if it's like Progressive or whatever, where it's like you're turning into your parents.
Oh my gosh.
It's like, we all see it.
Yep.
We all see it. You know, it's like, I just feel like that's how it is. We all see it. And yet there's not enough people to want to make that change. It's just, I think because everybody's tired of fighting the fight,
Yes.
you know, and then like you said, you'll get people back in. It's like, okay, I'm ready. I want to do this. But then everybody else is just beating them down. And you just think, okay, I can't be in my silo, my one single person trying to make a change.
Yeah.
Everybody has to be willing to do it.
Yeah.
And in the medical model, I feel like it's viewed as the person is the problem. Give them a diagnosis, fix the diagnosis, and that's it. It totally takes away their environment. It totally takes away the things they need to do every day. It's just, let's just say blood pressure. We fixed your blood pressure.
Yep.
You're out.
And that, I feel like it's getting worse and worse. Like we went, you know, if you're in acute care and you've been in there for several years, you know the pressures of expediting discharge are just getting heavier and heavier and heavier. And I mean, even like making a certain discharge, like I've heard some colleagues say that like you can't even say acute rehab anymore, like specifically.
No, you can't. Nope.
Because like the case management they want like an option A and an option B. They don't want you to pigeonhole, because if you don't specifically say which one, then they can put them where. And if you want to elaborate on that, because that's just the little bit that I know.
So at our hospital, and this is also actually talking to other hospital systems within the region. So no longer can we say skilled nursing facility or say inpatient rehab. We can't say those specifically. It has to either be high intensity post-acute inpatient therapy or post-acute inpatient therapy. So again, everyone sees it, everyone knows the high intensity means more than likely you want this person to go to inpatient rehab.
Yeah.
Just the post-acute version, it could go either way. So if the patient progresses, there's still that option of going inpatient rehab, but if they don't, then they'll do skilled nursing. And it's more from an insurance perspective, because I guess insurance companies now are like, oh, well, you said SNF from the get-go, so like that's the only option. And they totally, again, take away the person as a whole and these factors that contribute that could change them to progress. It's like, nope, day one, they were SNF. That's it. That's all we're paying for. And so I'll get phone calls all the time like, I need you to change your note to say this. And I'm still like, no, I won't do it.
Still gonna not do this.
I'm like, it's not ethical. I think I go back to that too. Both of our professions have to take an ethics exam essentially. And at least for OT, we have to get a continuing education credit every year for ethics. And so I just go back to that. I'm like, is this ethical for me to do this? If my answer is no, then I'm not going to do it. But with the like home health and outpatient, I still think we can say those things. But then same thing, somewhere in my note, I might have to say like, but if returning home, patient would need blah, 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 blah.
Right.
So it's like, no matter what, you have, I'm exaggerating, 10 million options for this person, even though there's one direction that would be better, but
because it's like we just need to get them somewhere else other than here.
So we don't have to,
whether or not what it's the most appropriate or the patient wants to or doesn't want to type situation. And why this is really important is because I mean, at least like when I was still working in acute care, starting out, I felt like we had so much autonomy with that. I mean, and this is one of the things that folks going into or considering acute care or hospital, you have this autonomy, like you get to help this person, like you get to put them exactly where they're supposed to be, and you have such a role in figuring out whether it's home or subacute, acute rehab. And that I always felt really that gave me a lot of value. And I felt so great that even if I was only seeing a patient once, I was able to set them on the right path. And I felt pretty supported in the beginning. And this has transitioned significantly over the past few years. It's not just at Maddie's hospital, but I hear this from colleagues in hospitals across the country, that we are losing that ability to make the right decision for the patient. And everyone listening, like, we want you to know that, because if you've been told like this is a big piece of what it makes that setting fulfilling, that
it may not.
It may that ability, that autonomy it unfortunately seems like it's going away.
Well, and that's why I guess I'm kind of numb to making discharge recommendations because, again, ethically, I'm like, I'm going to choose what I think is correct for this patient. Yeah. However, also in the back of my mind, I'm like, well, at the end of the day, they're going to do what they want to do. Right. Whether it's the patient or the doctor saying, especially like surgical patients, the ones that come in for elective surgeries, most of them anticipate that their patients are going to go home. Yep. All of them. Right. Okay. So when they don't, it's, oh, I don't think they need that. So they're going home. And it's, okay, well, did you come look at the patient? Did you see how they were moving? Were you with us when we mobilized them, when we had them do their self-care? No? Okay, then how do you know what this person is? Because again, medical model, you had this problem, I fixed it. You should be good, and we're discharging. Yeah. You know, whereas we see all the other factors, like Memaw lives by herself, and she just had this knee surgery, and now she can barely stand up by herself. Maybe it's pain, maybe it's coming off anesthesia, whatever, and you fix the knee problem, so she's got to go, but lives alone, has stairs, now can't get on and off the commode. You know, it's like, you know, this person's coming right back. Right. And when the solution could have been, how about we give them exceptional care right now? Like, if they could be here for 2 days, we could give so much therapy for 2 days to set this person up. But instead, nope, I fixed your problem, so you gotta go home. Yeah. And
it's, if you're in that setting and you've fought this fight, which probably a lot of you have, or you do daily, it is exhausting.
It really is.
And after, it's like, I could have spent time seeing another patient and giving excellent care to another patient, but you were trying to put out fires and fight and fight and battle and battle. And it just becomes, again, insanely exhausting after some time. So if you were to say, like, if we talk like full scope OT, and I don't want to go too deep into that because like Alex Germano, Luke Deppner, they had an amazing interview that talked about OT, full scope, and kind of the relationship between PT and OT. So I highly recommend y'all listen to that interview. But
it's really good.
It's so amazing. I learned so much. But if you were to say like someone who maybe already has a fitness forward philosophy or wants to use a full scope, you mentioned some of them before, but like what would you say someone, an OT in acute care, if they're using their full scope, what are some of the exciting things that you can do? And maybe it's not 100% valued all the time, but what are those wins that when you've been able to use your full scope? What are they? And just, you know, how does that feel compared to like when you are, we're doing bathing, dressing, giving you a reacher, put your socks on and off.
So I think what's really unique about occupational therapy is we are taught to do a task analysis, and y'all may do the same, but it's essentially taking that task, and I'm not kidding, breaking it down piece by piece by piece. What cognitive skills do they have to have? What physical skills do they have to have? What socioeconomic skills and awareness do they have? It's looking at the whole picture of how to help with this, right? So in acute care, adding the fitness forward component, I think one of the most exciting treatments that I've ever done is, it was a patient who had COVID, really was just truly just having some respiratory issues. I mean, they did have to have a lot of oxygen, but otherwise stable. I came in there, like, did my spiel because I feel like I have to, you know, like I've kind of actually watching some of Luke's videos, actually, I think it's OT Inpatient on Instagram, but
follow that handle.
Yeah. But he talks about, you know, you're told, hey, you got to tell the patient what occupational therapy is from the get-go. And when I saw his video, I thought, why do we do that? You know, because when you say it, most people are just like deer in headlights, almost like, okay, you know. But, you know, I was kind of telling him my spiel, like, I mostly look at self-care, blah, blah, blah. And he's like, well, I mean, I've been doing that in this room, right? You know? And so I was like, okay, what do you want to be able to do? And he's like, well, I think he was a contractor. He's like, I have to go up and down ladders. I have to hold hammers. I have to do, you know, all these things. And I said, okay, if there was one thing I can do with you today, what do you want to do? And he was like, I want to be able to move my body like I would in that capacity. And I said, okay. And so like on the fly, I was like, okay, we got a small space, maybe we can do, you know, we say sit to stands, but just, you know, air squats up and down to a surface. I was like, are we safe enough to turn around for him to do some chair push-ups? And then can we do just touching the floor, reaching up, touching the floor, reaching up? And we did that, and we did like a little, what we say AMRAP, you know, as many reps as possible or whatever. But we did that for 10 minutes, you know, and I was monitoring his vitals. I was asking him, is this moving in a way that you feel like you would have to do at your job? If not, let's modify it because I want to mimic that. And he's like, no, this is perfect, you know, and I could tell, it's like, okay, we're starting to work hard. I was like, on a scale of 0 to 10, 0, this is easy, 10 feels like you're running a marathon. Like, where are you at? You know, trying to modify as we're doing it. And I left that room just like, oh
feel
my
good,
gosh.
I nailed that one. Like, that was a freaking home run.
Yes, like I just felt so good because I was like, no, like screw this. He doesn't want to do self-care to put that in a box, but tying in the OTPF, there's verbiage in there that talks about those exact words. You know, it talks about muscle endurance, it talks about muscle power, it talks about flexibility and just all these things.
And like lift and carry, like these words that most people would typically think are PT are 100% OT as well.
And it was like, man, if I could do that
every time,
it would be so great. Instead of someone, let's say if someone had viewed, thankfully, because it was COVID, most of the time people can't see what you're doing in there. And, you know, I was like, man, I don't feel uncomfortable right now. I don't feel like I have to follow this routine that people think I'm supposed to do. And honestly, part of that was also this trajectory of like, I could do this way more often. You know, or even people, again, tying back COVID, I hate to do that because I know we're like coming out of it, but that was such like a pivotal moment.
Huge part of your life too.
And I think for other people were stuck in those rooms. And at our hospital, especially in the ICU, there were no windows, like just this dark room. And so one person was even like, she loved to color. Like, I just want to be able to color, you know? And so the next time that I came, I just brought pencils, colored pencils and a coloring book. And, you know, I kind of tied in other stuff like, hey, can we stand and do this at the same time? Or can you, I can't remember what those sheets are called, but you know the coloring sheets that have numbers and you have to match the color? Like a 1 is blue, 2 is yellow. Like, okay, that takes cognitive skill to figure that out, you know, so that was part of it too. Like, yes, we're coloring, but we're adding that cognitive piece to challenge your brain a little bit so you don't start having delirium while you're here. You know, it's like those moments where it's like, I'm actually doing something that the patient wants to do and it's actually in my scope to do this and this is fulfilling versus, you know, hey, we need to help clean this person up. I'm like, okay, you know, again, I'm not above doing it. It's more, man, I don't want to charge for this. Like, this isn't skilled. Anyone else in this hospital can do this. You know, but we just get almost forced to feel like, well, if I'm not doing this, then how am I going to charge and bill treatment? And so this isn't to knock anybody that's doing that, because believe me, totally get it.
You walk in the door, if there's poop all over, you're cleaning it up, regardless of PT, OT, whoever the heck you are. Like, you got to get this person.
And you find a way to charge for that treatment. Right? Because then it's like, well, we're doing bed mobility, we're doing this. I'm going to try to add that cognitive component. Do they understand what I'm saying to reach for the bed rail or whatever? But it's just, those are the moments where I'm like, man, anyone else could be doing this, I feel like. But yet I have to charge for this, and I just like, I don't like that.
And unfortunately, it's like, I feel like those type of sessions are what is like the majority of the day a lot of the time. Like those moments, and I had the same thing. When you have that really awesome session with the patient and you're doing an AMRAP with meaningful activities, and you're just like, you lose track of time because you're so happy. Like, you're just having this like awesome session. Those were so few and far between. I think that's what was so hard, is like, I didn't have enough of those on a daily basis to keep me in a mindset of, this is fulfilling and I feel like I'm bringing value. They were little blips in my screen on a day. And I like, that for me is like what contributed a lot to burnout. Is like, I'm fine, like, just like you, like, fine with doing that other stuff, because if you're going into that setting, you're gonna have to do that other stuff. But that other stuff whether it's walking into a situation like you just described, or you're fighting with providers, or trying to advocate to the end of the earth for a patient, you get nowhere. That took up so much time and energy and space that I was just like, I need to just take myself out of this environment.
Because it could be months.
Yeah.
That you have a treatment like that.
Months. Oh my, yes, you're right. Which is like, if you all are in settings that are outpatient or home health, outpatient on wheels, just not the hospital, private pay, and you are able to have a meaningful session every single session, like you were living in luxury.
Yeah, gold. Like, that's amazing.
Yeah,
I need to meet these people.
yeah. The hospital, exactly. It could be months in between having a really meaningful session like that, and I think that's what can burn a lot of people out.
Well, and even comments like, so I actually had to be on a surgical floor yesterday because there was a lot of surgeries for some reason. And again, don't mind it at all. Like, I can really, again, see any type of patient.
Yeah.
And someone said, because I had a bag that had like the adaptive equipment in it. They're like, oh, you got your OT bag. And I was like,
oh my God. The reacher, because OT equals reacher.
Yes. And it's like, it's something so, it's just one comment, right?
Yeah.
And like, if you hear it one time, not a big deal. But when you hear it again and again and again, you know that's what people think your profession is.
Yeah.
And that's when it leads to that burnout. And I even said, I mean, now I've gotten to a point, I'm like, well, like, there's a time and a place for it.
Yeah.
This being potentially one of those times, so I want to have it with me, you know, but other than that, or I've even had someone like, oh, you don't have your reacher with you. And I was like, because I want
like, it's an extension of your arm.
So I was like, I want to see what they can do before I just hand them this compensatory strategy.
Yeah.
You know, they might need it, but I don't know that, and I'm not going to automatically do that. And so I just think when you get those type of comments, not to say that's every day, it's certainly not, but it's enough over the last 7 years that's like, man, people just think it's about this, and that leads to burnout. And then I had a conversation actually with one of our physical therapists, even said within the first 3 months of getting out of school, they felt burnout. Mm-hmm. And I was like,
I'm hearing that more and more.
Yeah, I was like,
it's
you
so
too?
sad.
I mean, I felt that way, you know, and I even thought, there is no way I could possibly feel like this already. Like, that does not make sense, but it does when you have this expectation leaving school, what you actually walk into, and then add the other layer of people thinking this is what you do. Right. And so, especially as a new grad, you don't have that courage to say, or at least for me, I didn't. Right. No, that's not what I do. Or even now, I mean, it's taken that long for me to finally be like, you know what? This isn't all that I am. This isn't just it. Right. You know, there's so many other things I could be doing. Yeah. And it's just like, it's taken that long. Or hearing other people's stories of, I also felt this way. I also encountered this. It's like, okay, wow, I'm not alone in that way of thinking. Right. And I came across this, I guess, entrepreneur. I don't know how to describe her, but her name is Rhiannon. She does the OT lifestyle movement. Mm-hmm. She has a website, podcast, Instagram. I have been so inspired by that because she interviews all these OTs that are doing things outside of the medical model that I'm like, these are my people, right?
Yes,
like,
I love it.
Even though they may not be doing the type of work I want to be doing, but knowing A, they felt the same way, B, they actually accomplished doing what they want to do, it's just been incredible. It's like, you know, the timing has been interesting because, you know, obviously we did our presentation. I think almost immediately I made that Instagram page for myself, OT Revival NC, and then I was going to start that path, and then big life event happened, right? So it kind of like put that on pause a little bit, but I'm still trying to like hear you, and I'm trying to hear this OT lifestyle movement person, and I'm trying to still even keep that kindle of a flame going, you know, because I don't want it to just stop. And, you know, I've even just been trying to like use that account to do, this month I did like 31 days of wellness, you know, because health and wellness is part of the OT profession, and not saying that's totally the route I'm going down, but it's like, okay,
you're just getting curious.
Yes, outside the medical model.
You're starting to look for things outside the medical model. And so like Maddie hasn't just like I'm quit, right? She hasn't just walked out of the hospital.
Nope.
This is, it's going to be kind of a gradual transition where she's still doing hospital, but spending other time kind of just listening to podcasts and exploring other options. And so talk about kind of what that transition is looking like for you, like what your job is going to be looking like coming up, your actual, your hours, and then what other things have you started exploring? Because I know people are kind of like, I may be thinking about getting out of this thing, but I don't know what else to do. What else can OT do? We obviously talked about just like being full scope OT a little bit, but outside the medical model, I think a lot of people are like, I don't even know what to do or where to start. Yeah. So what has that transition look like for you, and what is like work going to be looking like for you?
So yeah, when you wanted me to come on and kind of talk about this, I even thought like, well, I don't even know what I'm doing with this, so how can I speak to what is going on, but like you said, okay, maybe it would be helpful for someone to see, okay, this person is truly at the very beginning of, okay, I'm actually trying to make this leap, right? Like thinking about it has been at least like 2 years in the making, because you and I have talked a long time about it, but like, I wish I could say what triggered that final. I think it's just accumulation of things like we just shared. Yeah. Being tired of the medical model, doing that presentation with you, hearing other people. And
so just to clarify what this presentation, so Maddie and I, we did a joint presentation for the NCOTA. So we got together literally in this same room. And we put together a presentation talking about PT and OT collaboration and how we can provide holistic fitness forward care and what that looks like. And then Maddie actually went in person and presented it at the NCOTA conference. So we had a lot of like conjoined learning of OT scope and PT scope, and how do we put that together to inform students and clinicians on how that relationship can be very, very effective using health, wellness, fitness forward kind of as the foundation of providing our care. So that's what that presentation was.
And so I think doing that and then finding that podcast and hearing other people doing other things, it was just, wow, like, okay, why am I not doing this?
Yeah.
Why not? What's holding me back? What's keeping me from moving forward? And part of it is like, well, whether we value money or not, we all have to have it.
Money is a thing.
Yes, to some capacity. I mean, you have to have it. You have to have it for food. You have to have it for shelter. You have to have it for gas, or even if you're not have your own car, you have to be able to have it to take a bus or get an Uber, whatever. Like
diapers.
Yes, diapers. I have to feed my child. I think part of it was like, oh man, if I just jump ship, I'm taking a really big risk here, and not that you all know me, but I'm like, I want to take risk, but my practical brain is just way too strong. It just is. So then it was, okay, can I not do both? Do I not have time to do both? Like, okay, where's the barrier there, right? So then I just proposed to my manager, hey, can I have a different schedule? What would that look like? Is there an option to do 32 or 30 hours, or, what is possible? So what came from that is, okay, we can't do 30 or 32. I won't get into those reasons, but it was, you can go part-time. And what that looks like for me is over a 2-week period, I will accumulate 40 hours. Cool. However that looks. So,
well, that's sweet. It's flexible. Yeah.
So for me and the person that's going to do, essentially it's a job share, right? Yeah. So let's say over a 2-week period, week 1, I'll do Monday, Tuesday, Wednesday, you do Thursday, Friday, and then we switch the second week, and it'll just be back and forth. So checkbox there, right? Like, I'll have less time at the hospital, more time to explore.
20 more hours of life is given back to you.
Yes.
Okay.
These other options. So I still am able to make money, have insurance, whatever it is that I need for stability. Yeah. So there's that. So now with that 20 hours, it can be anything. I know. I'm still like, what do I even do with that? So it's going to be like, I'm hoping part of that is, okay, let me, either write down, or I like the activity you told me about the other day. Let me write down what I'm doing in my career, right? Yeah. And you started to kind of feel internally, this really excites me. Mm-hmm. This doesn't make this other thing not important. It just means, hey, maybe more of my effort or more of my clinical reasoning or whatever is going to go towards this thing that excites me. Yeah. So I think for me, it's going to be that first step, or even noticing in the past 5 years or even year, what has lit me up, you know? And part of that is health and wellness. Like, I know in a nutshell, health and wellness is what I truly, truly enjoy. Yeah. If I can help take someone from point A to point B and feeling better about themselves, like, I just love doing that, you know? But then also part of it is, you know, I'm a new mom. So if he's a year old, I think seeing that whole progression, it just blew my mind how little support new moms have. I mean, really and truly, I was like, this can't be how this is. And that's even, I was given exceptional care, really. I mean, I had great pregnancy, my labor and delivery, no issues. Like, from a medical model standpoint, all my needs were met. Right. Everything went fine. From a environment add-on to my daily activity mindset, absolutely not. Like, I have thyroid problems even before pregnancy. Well, no one followed up to be like, let's check your thyroid. It was like non-existent. So I went hyperthyroid. So I was having really bad insomnia, anxiety, depression, which hormones could play a role, absolutely. Totally. But like, well, if someone had even cared about me as the mother, not just, oh great, you birthed a child, let's worry about the child. Yeah. Maybe someone would have caught that. Maybe I wouldn't have had that as bad. Or it's almost like, to be totally candid and transparent, I almost feel like you have to say something like, I'm thinking about harming my child, for someone to actually take you seriously. Yeah. You know, I didn't have to get to that point of saying that. I mean, I finally just was like, I think with my provider after the 2-week period, I was like, I'm about to check myself into a like inpatient, like psych unit. Yeah. And even though, did I really feel that way? Not really. And I know some people do, right? But it's like, you have to go to those lengths for someone to take you seriously. Like, I don't understand that, you know? And then even like the body mechanics for feeding your child, whether you're breastfeeding, bottle feeding, rocking them, or if you had a cesarean section, like body mechanics to get in and out of bed. Like, I just feel like there were so many gaps of care that, like, man, not that it's a simple solution, but there's so much more to it that I could play a role as an OT helping that for like maternal wellness, you know, like it could be trying to conceive to the postpartum phase. There's so much that can go into that like that triggered the, okay, what about pelvic health? People recognize that terminology, right? And so then it was, okay, why do only physical therapists?
I was gonna say, it's always a PT thing. Like, pelvic PT is you understand that concept, but it's like, well, what about OT? Like, you are that profession, I feel like, from a full scope perspective, like, is perfectly suited to be in that world.
So I don't know how historically physical therapy got attached to that. And it's no, like, I'm not saying, PT, why are you doing this? You know, it's not that at all. It's more like,
the merrier, get both involved. So, like,
why can we not both be involved? You know, and especially, it's so hard to put language to it sometimes, because I feel like there are a lot of things that are crossover, but it's just the way that we're taught in school. I feel like our two lenses are totally different, you know? So it's like, okay, take those two different lenses to help this person. Right. And kind of like we've talked about, repetition. Yeah. No matter how you want to use repetition, it's like the more someone can get this information and the more they can use it, it's going to stick. Yeah. You know, it's just like, I learned about spinal cord injury in school. Yeah. There's so much related to that I'm like, I have no idea. You know, I would have to go back and look it up, because I haven't had repetition. I haven't had constant reminders of doing that. But yet we expect patients. I told you this one time, you got it, great job. Right. So I think I'm just in the space of exploring what it is I really want to get to, networking, making connections, just finding my people that are also in that same boat, you know, that have shown you really can do something else. And especially at MMOA, with the older adult community taking that class, even that, like, phenomenal, you know. It's like, I love that they also believe, again, repetition. We got to be doing this for everybody and sharing this information to help our clients get better. And making those connections with y'all that then leads to somebody else, you know, and it helps you realize, man, there's other people out there. So I would definitely say I'm in that exploring phase of what I want to do next, and not trying to just, like you said, jump ship. I can't. Like, I wish I could.
And most people, I think most people are exactly like you. They're not necessarily 100% risk adverse, but their rational mind is like, I have to maintain a level of stability. And so I just think it's a beautiful thing to think full scope OT in the realm of pelvic health or pre-postpartum. It's amazing because it's such like a population that needs more support. And so obviously, like, your experience of being a mom and an OT you started to think like, well, I wish, you know, we could do something here, and the body mechanics and all of that. And then you mentioned the OT podcast. Now what is that? Say that again. So
it's OT Lifestyle Movement.
Okay. That's the Instagram handle?
Yes.
Okay.
But it's also her podcast. Yeah. Okay. And she also has a website, OT Lifestyle Movement.
Got it.
It really is. It's incredible. Like, there's people on there that do, like, wilderness recreation. There's someone that's kind of more into counseling. There's someone even in the school system that's trying OT school, not like pediatric school. OT school, trying to kind of reframe what we do as OT, you know. And I'm like, this is incredible. You know, it's just so cool to see that people are using their scope of practice and just being confident in it. Right? Because I think that's part of it too, is for so long believing the narrative of what you do that you're apprehensive to, wait, can I do this? You know, am I gonna, like, look bad or get in trouble, or is this under my license? You know, there's just so many questions, even for me, that I still have. But seeing other people out there doing it is amazing. And
so you're getting inspired by other individuals who are doing this, right? Even just
across
something like across the world. And it's like it's a podcast, right? You don't know this person, and you don't know this person, right? You just started consuming information that's out there. And that's so powerful to just get the wheels turning. Now, within pelvic health in particular, so you start to narrow a little bit, are there any people, like, whether it's Instagram or another podcast, or what you're doing, like, in your community, trying to learn more about OT and pelvic health? Like, anyone that's really been inspiring to you, if they're public, then throw out their handle, or kind of like what you're doing from a in-person standpoint to go learn more about that.
So Lindsay Vestal, she's the Functional Pelvis, I think is her Instagram handle. She's an OT who does pelvic health, and she has you can get continuing education to learn more about pelvic health. Because I don't know, maybe OT programs now maybe you're doing more. I have no idea in relation to that, but I certainly didn't learn about pelvic health in OT school. But I took a OT Pioneers course that was basically foundation. What is pelvic floor? What is it? You know, she has some amazing content. She does all kinds of courses. I love how she's starting to learn this component too, which I also believe in. It's not just the biomechanical aspect of pelvic floor, it's like the biopsychosocial.
Ooh, I love that.
That's component of pelvic floor. And I almost feel like, not for everybody, but in general, that's, to me, kind of the difference between OT and PT lens in relation to pelvic floor. Because to me, I'm like, okay, you could have muscle tightness or weakness. Have you also had trauma in your life? Have you also had a baby that's kind of altered hormones. Like
Yeah.
there's just so much more to it
More
than
that goes into
just muscle weakness, tightness.
Right.
But yeah, she's phenomenal. I love following her. I took her course. A person that we know, Brooke Mackin,
Yeah.
not that she's like hugely promoting what she does, but I mean, she's also taking those courses. I think she's trying to incorporate pelvic health with Gateway of Charlotte. I think that's
yeah,
it.
with Allison. Yeah.
Yes.
Okay, cool.
So she's doing that. So I kind of
Very
follow
cool.
some stuff she's doing. With the OT Pioneers, they list people you can look in your state if an OT is doing pelvic health. So there's 2 in Winston-Salem where I'm at. I plan to reach out to them. There's 2 more pelvic health PTs that I've been in communication with. I can't think of their Instagram handles. Cole Camden, it may be like Triad Pelvic Health potentially. And then maybe Taylor PT Wellness.
Okay.
Something along those lines.
We'll go ahead, like in the comments of this video, we'll put in all of the handles and Maddie's
Cool.
handle and all of that stuff, so you guys have something to
Yes.
reference for sure.
So they've been resources. They put out really great content. I think my ultimate goal would be taking all that information and then not recreating the wheel, so to speak, but just
Yeah.
making it into my own, right?
Yeah.
Like I would love for it to not only touch mental health components, but also fitness forward, providing exercise programming to help
Yeah.
with trying to conceive to postpartum, and then pelvic health. Like,
Yeah.
okay, there's a lot of stuff changing.
Yeah.
We gotta address this.
Yeah,
you know, but
Maddie was just telling me, like, she walked in the door and she's like, it's been a year and my insides now just feel
like 85%.
85%.
Yeah, back to normal.
Like,
Yeah, I mean, it's just, and then that's the thing, you don't know what's normal.
Yeah.
Right? Like, after 3-4 months, I was like, man, I'm still having a lot of, like, pelvic pain. You know, so
Yeah.
certainly I reached out to someone who had more knowledge, but, like,
Right.
it's like, oh, yeah, like, that's just, no, I shouldn't say pain is normal. It's not atypical that you're still having
Sure.
this.
Yeah.
You know what I mean? And so it was like, oh, okay, I wish, like, in your pregnancy visits,
Yeah.
that you have so many visits, okay? Like, so many.
Go to the doctor.
I know, I'm like, at first it's like every 2 months and then it starts becoming weekly. You would think within all of those appointments that each one, like, little bits of knowledge could be given to you about what's happening with your body.
Yeah.
Right? Like, not just checking on baby. Obviously super important. You want baby to be healthy
Right.
and everything's going okay. But I think that would take 5 extra minutes to say, hey, you know, you have thyroid problems. Let's make sure we circle back to that.
Yeah.
Or, you're gonna have some type of pelvic pain for at least 4 months.
Right.
Or, sex may not be the same as you thought it would be. Or you might be really constipated. Let's come back to that.
Yeah.
Or here are some resources if you have postpartum depression and anxiety. Not just, oh wow, you have it now? Okay, let's try to fix this.
Right.
Because I truly 100% think my experience would have been different had I had that type of information.
Yeah.
Because even I had to ask Hunter's best friend is in social work. He has more of a like counseling therapy side of social work. He was the one that found the postpartum resources for me.
Wow.
Because I was like, I don't even know how to find this.
Yeah.
And I'm like, as a pregnant woman,
yeah.
this shouldn't be
This should not be
that
something
hard.
that you are searching around for.
Yes, it should be so easy.
Yeah.
You know, so I just feel like those are the gaps in care that occupational therapy could help with.
Yeah.
You know, do I think it's going to be a hard road and battle to get, again, kind of that concept of getting people to buy into it?
Right.
Sure.
Yeah.
And I also anticipate, I guess, or hopeful that it won't be as hard because of the focus. Like, this is the one area I'm trying to do, and picking those providers, like, hey, we can do this for your clients. In my mind, I'm like, why would they not want that?
Right.
Why would they not want to have a member on their team who can address these things if maybe they can't or don't have time for?
Absolutely.
You know, because it's so hard to be the one person providing every bit of care.
100%. It's never supposed to be that way, right?
Yes.
And it's just about like, and now you'll have the time, those extra 20 hours in a week to like go network and find the providers that share your same philosophy. You are no longer, you know, in a hospital that you are just taking what's being thrown at you. Now you get to go out and hand pick and learn from folks who share your same philosophy and learn from them, and then you're just kind of developing that circle that wants to provide the same care that you want to provide. And you're going to find individuals who value that type of care, and then we're all like walled in.
We work together.
We all work together. Everyone's on the same page and same philosophy. I love it. So it reminds me of, this is it from a TED Talk. Megan Daly, she's a TA for ICE in multiple divisions, but she sent me a TED Talk, and I loved it because the very end of it, I don't really remember what the title of it was, but it was like, how do you create the life you want, basically? And it was, I think I mentioned this to you, but it was like, get curious, talk to people, try stuff, and like just rinse and repeat that over and over and over and over again. So we'll end it here. Me and Maddie could talk literally all day long. Instagram already turned off on us because we were talking too long, which is fine. But I think this is just, you know, get curious, talk to people, try stuff, right? And if any of you are in the medical model, you're wondering about stepping outside of it, especially if you're an OT, if you have any interest in in pelvic health at all, Maddie is going to be an amazing resource to reach out to. So again, we're going to put all of her handles and the other resources that she mentioned. We'll put that in the comments here in the show notes. But what is your handle that you just started?
So it's OT_revival_NC for North Carolina.
Got it. Yeah, perfect. So reach out to her. She'd love to talk to y'all.
Even if you're feeling burnout.
Yeah.
I will, not that I'll give you inspiration, but I want to hear you and I want to see you. So, yeah.
Totally. And again, like this, she's like Matt, and again, why this is so great is that she's in the thick of it. This is not someone who's like, her knees are still straight. That's totally a Brene Brown thing, but like they're still straight, right? She doesn't have the scars, and she's telling us how to do it. She's figuring it out, and y'all who are in that same spot, y'all can figure it all out. We all can figure it all out together.
Absolutely.
So, all right, we're going to end it here.
Thank you again so much.
This has been awesome. And this is not the last time that you guys will hear me and Maddie just talk your ears off about stuff. All right, y'all. Have a good rest of your Friday.
Yes, thank you.
Let's see.
So let me look up some of those